Thank you.
Army should.
Hey, good morning. As it's 11 o'clock, we'll go ahead and get started. Thank you for joining the University Hospitals Health Services Research Grand Round, supported by UH Health Services Research Center. My name is Dr. Anna Maria Hibbs. I'm a neonatologist and Vice Chair for Research at Rainbow. I will be your moderator to facilitate today's talk. Before we start, a few housekeeping notes for our audience. This webinar is being recorded and will be available to view from the UH Research and Education Institute website. Please mute your microphone throughout the presentation. If technical assistance is needed, please contact RNAT member Nicole Bollinger, who is on the call. If you want to ask questions, you can type them in the Q&A. Questions can be seen by all attendees, and you will have the option to submit them anonymously if you prefer. With that, it's my pleasure to introduce our speaker, Dr. Beth Tarini. Dr. Tarini, MD, MS, MBA, is the Richard and Agnes Hudson Endowed Chair in Health Services Research and the co-director of the Center for Translational Research at Children's National Hospital in Washington, D.C. She's a professor of pediatrics with tenure at George Washington University and a Robert Wood Johnson Clinical Scholars Program alumnus. She's also served as a past president of the Society for Pediatric Research. Dr. Tarini's research is optimizing the delivery of genetic services to families and children, focusing on state newborn screening programs. Dr. Tarini's research has been funded by the National Institutes of Health, HRSA, the Robert Wood Johnson Foundation, and the Cystic Fibrosis Foundation. Dr. Tarini has also served in several leadership roles in newborn screening policy. At the national level, she is currently a member of a National Academies of Science, Engineering, and Medicine committee entitled Newborn Screening, Current Landscape and Future Directions. At the federal level, she served as an appointed member of the Advisory Committee on Heritable Disorders in Newborns and Children. This committee advises the Secretary of the U.S. Department of Health and Human Services on the most appropriate application of universal newborn screening tests, technologies, policies, guidelines, and standards. At the state level, she has served as chairwoman of the Michigan Newborn Screening Quality Assurance Advisory Committee and the chairwoman-elect of the Iowa Congenital and Inherited Disorders Advisory Committee, both of which make newborn screening policy recommendations to state legislatures. So without further ado, please join me in welcoming Dr. Tarini's presentation.
Thank you, Dr. Hibbs, and thank you all for kindly attending and for inviting me. As you can see, I'm a health services researcher and try to focus my research on issues that will translate into policy, that the research does not go only into, shall we say, stays, or shall we say, within the ivory tower. So with that, I'll start. And I do want to encourage, if there are clarifications or any specific questions during the presentation, please do put them in the chat and we can clarify, and or if I can pause, we'll go deeper. I do want this to be interactive. And with that, let's go. So the goal here is to demonstrate to you that there's a gap in newborn screening, which has been my area of research since I had a K award from the NICHD, and then subsequently now 2 R01s also from the NICHD. So I began my career identifying the gaps and then working to fill them. And so I have no conflicts of interest to disclose. And so the goals today, just to make sure I do this just as a matter of level setting, I go through a very brief history, purpose, and implementation of newborn screening, so we all get a sense of what's happening in it. And then we're going to go on to the data gaps. First, I'll talk about the false positives project, and then I'll talk about the uncertain prognoses project. And then I'm going to summarize the active research projects that aim to address these gaps. And I apologize in advance. There will be no fancy regressions here. We have just finished our data collection in the false positives, and we're just beginning that in the uncertains. But I can share from the false positives where we are with our total, with our recruitment and our descriptives and what we've learned so far. And then happy to dive deeper into what we believe what we have as the analysis plan. Oops. So with that, I just want to first set the playing field. That newborn screening, some people often think of the blood spots in the upper left corner. In fact, newborn screening is done now through other point of care tests, including on the right, you'll see the cardiac test, the oximeter for the congenital cardiac screening, as well as the picture on the bottom middle of the hearing screen. Historically, the oldest of these is the blood spot, and that's the one we're going to focus on today for several reasons, but most of which that's the one for which we have the most contextual and background data. So a few things we should understand. This is a mandated public health program. It's in quotations because the public health lawyers will debate what mandated means. If there is technically no consequence, is it really mandatory? What it is in most of the states is an opt-out under special circumstances that are, usually very narrow. And that's just something for you all to know. This program is administered by the states at the state level. The states develop, direct, and implement that. They majority finance it with maybe some dollars from federal programs such as Title V. The screening we're talking a volume of 4 million infants a year, screened in the first 48, sometimes often to 72 hours of life. And there is some federal oversight in quotations, because the feds don't really also have a mandate. This is a federalism issue way back from your 6th grade civics class. And so this is not necessarily an audience where I think this is going to be new, given that your health services, but I have this up here because there are many people who say, because I look at the ways in which the program can be optimized, especially around false positives, I am stating implicitly that this is a program is problematic. And in fact, I am not. I believe that newborn screening is a successful program and it should continue. But as a health services researcher with epidemiologic training, I feel compelled to remind the audiences that all screening has harms. And it is unethical to ignore them, especially in a mandated program. And failing to examine them counts as ignoring them. So I put that out there just to give some context to why we're looking at these issues. So here I have harms of screening by Harris and colleagues. They propose a taxonomy in applying it to lung cancer. And again, this is the issue, I'm sure not uncommon to many of you, that screening itself has benefits and harms, and those need to be weighed such that the benefits will outweigh the harms when you have a screening program. Now, the definition of harm that Harris and colleagues use is any negative effect perceived by patients or significant others resulting from screening compared with not screening. So this is very broad, and they bring these four domains, of harm: physical, psychosocial, financial strain, and opportunity costs. We have largely focused on the psychosocial harms in our projects for a number of reasons. Mostly because the physical harms are minimal. Two, we have a terrible, terrible history of being able to quantify, either collect cost data in newborn screening and or quantify it, including opportunity costs. And so the data is just not there. So this is what we have focused on, and this is traditionally what has been focused on in newborn screening in general. And so first, I'll take you through the false positive results project. Any questions on newborn screening before I move forward, I'm happy to clarify. So feel free to raise your hand or put your question in the Q&A or the chat. So I'm going to take you through again to level set on what is a false positive. Again, many of you may know this, but again, just to level set, we have the blood collected at birth, shortly after birth, and the results come back from that card sent to a laboratory. They come back within range or out of range. And then when it's out of range, you get additional confirmatory testing and evaluation, and then you get 3 possible categories. You can be confirmed, the child can be confirmed as truly positive, meaning the screening test, which indicated the child was at risk, increased risk of disease or condition, having a condition is true. Getting conclusive, meaning the test cannot rule the child out as having the disorder in question, or the confirmatory testing can conclude the child has no condition, has the condition of interest. And in that case, it's called a false positive, and the clinical management is none. The family and the child are sent off. What they're explained is a separate issue of sort of unknown, but anecdotally, I can tell you as a general pediatrician, we tell the parents this was all a mistake, in that sometimes these tests are out of range, and this is why we do the additional testing. Your child is healthy, and you're sent on your way. So historically, we felt generally that we've told the parents that the child is healthy, and so onward they go, and the case is closed as far as we're concerned. The question really is the case closed as far as the parents are concerned? And so I put this here as a reference to 1968, the PKU anxiety syndrome. And I'm going back into the psychosocial arms. I put this here because, number one, it's 1968, so we're, 54, 56 years from this. So this is not a new issue in newborn screening. When you read this, you could be reading about the conversations we tend to have, some elements in the federal and state policy realm today, that they've been noticing a steadily increasing number of parents suffering from what they call the PKU anxiety syndrome, acute and chronic anxiety that ranges in severity. And here it is. The parents persist in the belief that their babies are or will become, see the time era, they use the term mentally retarded, we'd say cognitive impaired, despite repeat negative tests and considerable reassurance and support from the physicians. In essence, parents are saying the test says the big board of health showed that my baby was mentally retarded. Then a doctor in a little cubicle in the clinic did a test and he said he's all right. He's reassured, but I don't know. And so I often in my career have sort of taken the stance of trying to look at things from the patient's perspective. And this is an interesting one, I think, because the parents are saying, we would say as practitioners, well, the first test is extremely sensitive and not specific. The second test is very specific and not sensitive. But to someone without training, they might say one test is positive, one test is negative, flip a coin. How did we get here? So there's that piece of education. There's also this lingering belief that there's something has gone awry with the child's health, despite our reassurance. And this really harkens back in some ways to this very famous article by Green and Solnit about the vulnerable child syndrome, in which this is a case series in which they collected data on children after, in Indianapolis and New Haven, after they had a near death, if you will, experience. It's not SIDS, they were in the ICU, they were very sick, they had never been seriously ill before, and afterwards, even though they came back to full health, there was this lingering sense that there's still something vulnerable about that child. In some ways, there's similarities and there's differences, right? It's all about how this construct, I think, is conceived by the parents. In the newborn screening, it's more on a psychological conception that we've missed something and the first test was really right. Here, it might be a more of a threatened loss sort of conceptual model that now that child, that brings to life that the child is somehow inherently vulnerable, or has sort of brought to real case the parents' fear that the child could one day die before them. So regardless, these are sort of, I would say, can be transformative experiences. And the question we really have is, how do these experiences, are they affecting the parents and therefore the child? So in vulnerable child, you'll see difficulty with separation from the child. None of these will be surprising to you. Infantilization of the child, over concerns with their body and functions and symptoms. And ultimately, there's some studies that show some sort of leakage, if you will, or persistence into school age, into school underachievement. And so the question then becomes, well, what do we really know then of the similarities between this issue and newborn screening? And this is a busy slide. It's got multiple layers to it. So I'm going to take you through each layer. So the first is to orient you to the time. This is from 1980 to 2010. And this shows you in 30 years. Now, newborn screening started in the 60s, somewhere before that, somewhere in the mid 60s, it started first in Massachusetts and then spread to the States. So you're about a little under 20 years from the first newborn screening here. So in this 30-year era, you can see the number of studies that are on false positives are 1, 2, 3, 4, 5, 6, right? 7, 8, 9. So that's what's that? In 30 years, that's like one study every 3 years. So not a lot for a program that screens 4 million children a year. The second you'll notice is the disorders studied, which vary, which we can talk about as a separate conceptual model, like does the disorder really matter? What is it, the conceptual model of the disorder that matters? And you'll see there's a variability by the color. And then this other thing you'll see is this purple line is when we had expanded newborn screening, when we went in 2005 from screening on average 8 to 9 disorders to screening on average 30 to 50. And how many we had, how many tests, 1, 2 2 studies at that time and since. And then the third is the star, which tells you the use of the PSI outcome variable, which is a parent stress index. So a lot of these studies have used qualitative, quantitative methods. They've not all used the same standard measure. And again, then you see we have mixed methods, a lot of qualitative, which, as you know, is hypothesis generating, and quantitative as well. And then you see the sizes within the boxes. And then deeper, you'll see the findings. At the end of the day, the take home of this slide is something that we've been debating, I would say, for 60 years in newborn screening, with 60 times however many million babies, but now we're screening 4 million a year. Granted, not all of them will have a false positive. But at the federal level, as you've heard, I sit at tables again and again, and people debate about whether we should screen and what are the harms, and we still wallow in like 9 studies. And so the thrust of this project was to say, should we put some data behind our concerns at the policy level so that we can at least begin to understand at a population level what's going on? Because as you can see, as you can see, these are these studies, some are international, some are in the US, but they certainly by and large are quite small. So we were funded by the NICHD to conduct this study. This is our logo for our project and our group. And here's the team's acknowledgements and thank you. A local, celebrity of yours, Dr. Goldenberg, is a co-I on this study. He's a co-PI on the next study with me that you'll see in a little while. And this is a multi-site team, and we're very grateful for the contributions and the collaborations of our state partners in Virginia and Iowa. And so I'm just checking to see any chats. Okay, so into the nitty-gritty of the study design. This is a multi-site prospective observational cohort study. Why is that important? It's important because there have been none of these. in newborn screening around false positives. Most of our data is retrospective, nearly all of it, I believe, or cross-sectional. And so we have now the ability to go in real time and examine what's happening with these parents. So that's the first piece. The multi-site is the piece because we are also at the population level sampling from the population. In some of the studies, they'll sample from a clinic or they'll sample from a population and mix the comparison group and the exposure group together, or the exposure groups themselves. So we've tried to have fidelity to that population basis. The exposure group is the parents or guardians of children who received a false positive result, and the non-exposure or the comparison group are those parents or guardians who received a normal result. And here are, as I mentioned, our two state partners. We continue the tradition of using the parent stress index, which is a validated 120 questions measure, focuses on three major stress domains: child, parent, and situational life stress. It has 5 subscales, I believe, and 1 total stress scale. And then we have additional measures related to child development, parent anxiety, vulnerable child syndrome, and the like. We've collected a ton of data. So if anyone has postdocs or is interested, please reach out, because we're moving now through our data analysis phase. So to give you a sense of the recruitment and the follow-up here, the data collection and the follow-up, we start here at recruitment. We identify in partnership with the states. I can go into the recruitment later, the public partnerships we have of false positives and controls. We send them a letter. Actually, I take that back. The state sends the letter. In this case, we did consent over the phone. We did not do online consent. We do that in our current, the second study. And then we have, again, we follow with follow-up call to those who've not responded. And then begins our study participation. This is all online, virtual. We don't meet, if you will, in person, the parents, or the participants, rather. Some of them are parents, some are guardians. And we have 5 surveys. First, they get an initial contact demographic survey, which I'll show you here. And then they move on through their ages every 6 months to get what we call their outcomes survey, in which we have the PSI, the ASQ, ages and stages for socio-emotional development. That's a secondary outcome. The promise to see if a parent is having anxiety alongside the stress index outcome, vulnerable baby scale, and a reaction to participation research questionnaire. And so these are all where the stars sit, our data collection points. And I'm happy to say, as of, I believe, last week or the week before, we have finished the data collection, which was no small feat, given the fact that we started June 2020, the year of the pandemic, but because in some ways this was a virtual survey and study, we believe that we actually got an increase in participation as parents may have been at home and may have had more bandwidth. So I'm going to give you some initial contacting demographics so you get a sense of the study population. Again, the wealth of data we have is here: the parent-child demographics, the pregnancy experience, the child's health, this newborn screening experience I'm going to tell you about, which I think is actually going to help, which was only a descriptive study, help, I think, inform how we think about education, as well as household demographics. You'll also see we have COVID-19 concerns here, because when you're talking about anxiety and stress in parenting, and you implement all of a sudden during a COVID pandemic, you start to have to account for that and add your data collection measures for that. So here's our counts from the survey 1. At the left top, you can see the cases. The bottom, you can see the controls. Iowa and Virginia are in 2 parallel horizontal lines. You can see the packets mailed to Iowa versus Virginia. Of course, Iowa is a much smaller birth state. Virginia is much larger. Virginia also has a much more racially and ancestrally diverse population. You can see the consented piece here. We call this jokingly the Emily Phillips effect. We're not quite sure why. In Iowa, we get such a high consent rate. It has been a mystery to us. It could be the Iowans having lived there. I just don't know. But those who consent go on to take the survey, and our ultimate attrition rate is somewhere around 10% or less during the 2 years, which I think is laudable. And you can see here, from the cases and controls, we have 542 parent responses and 467 controls. And then you can see, so that's no small feat, because many in the peer review said you'll never be able to recruit controls, and we were able to. So that's very important, and we're proud of that. We also were able to recruit a fair number of dyads, which when you see that, that means both guardians or parents in the home completed this survey, which will help us have additional data points. Often these studies will say we focused on the mother. I know, I can tell from experience why. It's often increasingly difficult to get the father, for whatever number of reasons, to complete the survey as a general rule. So, and keep them in. The anecdote is oftentimes the mother will go out to the and say, hold on, he's in the car, going to work, let me get him, and we're going to consent him and have him participate. We did remunerate the participants, I believe, at the entire amount was $200. If I'm not mistaken, it could have been a little bit more, but it was not an insignificant amount. But they did take a survey which was surveys which were quite long. So to give you a sense of who's in this population, and I should go back to say, so this is my punch point, which is we are the only multi-site prospective study of false positives ever in newborn screening. So if we've done nothing else, we've achieved that marker. We also are the largest of any study of false positives in the United States, or I think internationally. I don't know of another one with 1,000 cases and controls. I could be wrong, I could have missed it. But we are proud of what we've accomplished, because we really do think it will help propel if not propel, at least inform the policy making and the decisions we have around newborn screening. We also hope that it sits as a sort of exemplar of what we can do if we want to engage and involve health services in this public health program. That it is possible to get feedback from parents about their children and from parents about their experiences. Okay, so I'll get off my soapbox and move along. The demographics, you see the age of the parent. This is combined by case and control. The age 32 years, the infant, when we get them on the median, is 4.9 months. As I mentioned, preponderance, or majority, I should say, female 2 to 1. Fair, almost equal, but a little bit of a skew male. Most are biological parents, most are married. This is a bit of you see a large, this is where we need work on getting to parents who might be lower socioeconomic status, non-white, identify as non-white, any of the following, and or partnered but not married. So we skew a little on these. I can discuss this, which as I discussed with the NIH, of how to get the opinions of those groups, given the way we collect data in newborn screening. At any rate, I'll park that and we can discuss if others want. So it's important that we know, I note the only child, because there are many who believe the conceptual model is if you've not had children before, you might be a bit sort of primed to receive this news and not, quote unquote, handle it as well, not in stride, so to speak. We have almost 10% Latino population. And as you can see, we have a preponderance here of white identification with white race. You can see how Virginia helps us to diversify the population. And we have a not insignificant number of individuals who are not born in the United States. We have all of these. Dr. DeCamp helped us at Colorado with these questions about acculturation. Most speak English in the home. We have some Spanish speaking. I should say this study was, I should pause to say this study is translated, data collection instruments were translated into Spanish. So you could take the surveys in English or Spanish online in REDCap. You could also have them read to you in English or in Spanish. So we tried to get over the digital divide, and we tried to get over any literacy barriers. We had some markers of how well individuals spoke English and a question about health literacy. Again, we have a very educated population. As you can see here, over 49% bachelor's or master's and 40% 100,000 or more. We have the FPL stats. I don't have them here to translate that household income into something more meaningful. But you can see in the lower left what the census tells us. So we're a little bit higher, if you will, on these markers, which we knew. And most of these children, I'm going to go into just briefly so we can get to the next study. Most of these births take place in a hospital. This is, we're going to go through here to give you a little bit of advance notice what the experience is of the newborn screening. Here's the one part of the conceptual model of the impact of a false positive. Regarding the education piece and the experience piece, there's a belief that education plays a role because people are blindsided and they don't have a sense that newborn screening actually occurred. So when the provider goes to them and says, by the way, your child's newborn screen is out of range, they're like, what's the newborn screen? So there's been a real attention to how can we fix that. So a lot of people, very few opt out, but even when they don't opt out, they still don't know what happened. And so you can see that here. Another piece of the conceptual model that we have is that this is a bit like a signal receiver curve, which I can go into later. That being, the parents bring something to the table, and the messaging that they receive from the provider about the test also brings something to the table. I'll give you two examples. One, a parent who had multiple miscarriages or IVF in their pregnancy, who's on treatment for anxiety and has had a lifelong history of anxiety and had a difficult pregnancy, may receive a message very different from a mother or parents who did not have any of those experiences, may receive and process and cope with this experience different. And the other side, as it relates to the result, if as a provider, I were to tell a parent, your child is at risk of having congenital hypothyroidism, which is a relatively common rare disease, quote unquote, that affects children and is easily treatable with a daily medication called thyroid hormone. And with that, called levothyroxine, the child will have a normal life. That is a very different message than your child could have MCAD. And with that, before we find that out, you cannot have that child fast more than 3 hours at a time, because if that were to happen, the child could seize and have complications, even death. Also, if the child gets sick, please bring them to the hospital, because if they become febrile, we need to see them, et cetera, et cetera, et cetera. So you can see sort of what the parent brings as to the table and what the message brings as a threat can both influence, if you will, the outcomes. And to some degree, that we believe is agnostic of the different disorders that we look at. At any rate, I'm going to breeze through this. Many people come to newborn screening having know about it, having a different prior pregnancy, and we can parse these all out in the data and see if they didn't have the prior pregnancy, how they learned. Many of them will say, over half, they saw the blood prick, it was explained to them they were told about what was happening, and 40% say they were told when they'd received the results. And they are told this is what they give. The points here are the no, 33%, and the I don't remember. The other problem is some of these are normal, so we can't they may or may not remember because they may not be salient. At any rate, the piece here that I think is impactful for policy and education is we have focused in newborn screening so much on preparing people that it happens that when they leave the hospital, having worked in the nursery, we often sort of forget about a lost opportunity, which is to remind them that that test is still pending. We had in some of the cognitive testing, the parents say, well, they told me everything was fine. So it was done in the hospital. And so parents can, in the fog of war of birth, as those in the nursery know, can, things may be lost. So this is an opportunity for us when we discharge from the nursery to say, this test is still outstanding. Your provider should give you the results within a week. If you don't, please ask. That will help, I think, parents be aware, follow up, engagement, etc. So I'm going to breeze through these and then go, for the sake of time, to the next study. Again, I'm happy to return once we've processed all the outcomes and give you those, as well as go in deeper conversation in the Q&A. So the uncertain prognoses. Let me pause to say this. The false positive study was a study done 60 years after the emergence of the phenomenon. That's too long, in my opinion. Kudos to the NIH for funding this issue, uncertain prognoses, which is an issue of the last decade to 24, I would say 1 to 1.5 decades, so up to 15 years. Kudos to them to funding our project on this to get ahead of it, I think. So that you understand what I mean by uncertain prognoses. When we've come down this list and we get to out of range, we've already talked about the false positives, we get down to this, which is an out of range that then, if you get into confirmatory testing, can be true positive, can also be late onset, which we can talk about, or there can be this inconclusive. I'll give you an example. Excuse me, the child's is out of range for, we talk a lot about, lysosomal storage diseases. Their enzyme level is not 0, but it's not normal. It's somewhere in between. And lo and behold, we do additional testing, including genetics, and we see variants that were not seen before. This is not surprising to those of you with an epidemiologic background, that when you take a definition based on a clinical population who is severe and has come with severe phenotype to your attention, that when you go looking in the population, you will likely find additional, like the iceberg model below the surface, disease and or biochemical abnormalities that you were not aware of before. This happens again and again in newborn screening. We continue to be surprised. I think we're slowly getting to the point where now we're actually embracing this epidemiologic phenomenon. So therefore, if I can't tell you if your child has the disease or not, usually in clinical medicine or the condition in clinical medicine, I would ask you your history. This is why history becomes 80%, 90% of the diagnosis in some cases. Here I'm screening you, so by definition, you're asymptomatic. So what do I do? Well, the only thing I can do is surveil you or treat you. If my treatment benefit harms is I believe you have the disease or don't, and or my treatment depending how invasive it is. If you're asymptomatic and your MRI and other proxy outcome measures don't show any deviance, I'm hesitant to give you a bone marrow transplant that could kill you. So you can see where we get into the nettles, so to speak, with this. And so this is what we call now patients in waiting to some degree. This was coined by Dr. Kwan, Steiner, Timmermans, Buckbinder, this idea of that you're waiting for your disease, so to speak. They're not diagnostic dilemmas, uncertain diagnostic, because we will say we know the diagnosis, it's really the prognosis. And so again, based on this, as I said, this is an emerging challenge in newborn screening. And this is the current the R one we have, which is in its early to mid stages right now. And really, this has plagued this issue the last, I would say, 80% of the disorders we've added to the newborn screening recommended panel at the federal level. We have for this also a multi-state, a multi-site project. We've added partners Tennessee, Missouri, and Oregon here. We thank them. And so in this, the specific aims here, this is a mixed method study. So here we're going to determine, in its perspective, determine the longitudinal scope and magnitude of benefits and harms on parents after they've received an uncertain prognosis. So again, we're going to take and go forward with repeated measures, repeated data collection points up until 2 years. It's going to mirror in large part the structure of what you saw. We're not going to go to 2 years. We're going to go somewhere around 1 to 1.5 at a minimum. Some can go beyond, but that's our minimum cut. There's a number of reasons for that, which I can explain. To elucidate the longitudinal experiences of parents and their children who received an uncertain prognosis. Here we are highlighting our mixed methods approach. There's going to be, the PSI is the main outcome. We will have repeated measures at 6. I believe we're at somewhere around every 6 to 9 months. It gets a little bit wonky because of the delay in the diagnosis with these children. So it's not as crisp and clean, and we can't bin the children as easily. But we will do a REDCap online webinar data collection, web-based data collection, and we will also do recurrent interviews. And we are using those interviews back and forth to get a sense of how individuals how they're answering in the qualitative piece and how that can inform our interpretation of the quantitative. For someone who started as a quantitative researcher, it's very illuminating and helpful to me to see the benefits of the mixed method. And then the ultimate outcome is here, we will develop recommendations for programs to inform policies and practices that we believe will maximize benefit and minimize harm to children with an uncertain prognosis after newborn screening. And so we will bring together the multiple parties involved in newborn screening to see if we can put these findings into practice, if you will. I would say right now, I think we're upwards maybe of like 15 cases. And we're trying, these are much rarer than the false positives. We will need to have, I think we're in a 3-to-1 match if we can do it with a control, simply because we just can't get the numbers up. Ironically, the individuals we see are true positives and then uncertains. We have very few, maybe 1 true positive case, and the vast majority are these uncertain, if you will. The irony being, the whole point of the screening was ultimately, or primarily when it was implemented, was to detect these infantile cases that are to happen at birth. So, and when I say uncertain, just to clarify, we use uncertain as any diagnosis, or any time the parent is given the message that there is an uncertainty in the timing, severity, the timing or onset, the types of symptoms the child will experience, or the severity. So we use the parents as the marker of whether or not they feel that the prognosis, or to feed us the information about that uncertainty. This study has been a real interesting one to do alongside, or on the basic, almost on the heels of the false positives, because that one was so sort of defined and really sort of had clear boundaries around it. This is really exciting, but also challenging from a research perspective, because we are learning as we go, both learning alongside the newborn screening program, as well as learning from the parents, new information, what they tell us about their experiences. And with that, I'll pause here to open it up to to questions to give us a full 16 minutes or so. I know I ran through that, but I'm happy to go deeper in any part.
Thank you so much. If participants could put their questions in the Q&A, that would be really appreciated. I would like to get started with a question. As a neonatologist, I'm really curious if you have a preemie subgroup, and I know that's a population that has increased false positives and sometimes delayed results in stage testing. And, the parents are also at increased risk for PTSD
Yes.
and depression and anxiety. And I could really see it going either way, that it,
Yes.
the experience of all that trauma, or it sort of washes out with all the other information. So I'm
Yes.
really curious if you had that analysis planned.
Yes, you are 100%. And my answer is dullingly sad. The answer is no. Because simply from a grantsmanship, everything you say, Dr. Hibbs, is spot on what we think. The hunch is it's washed out, but who knows? It's still debatable. The issue became, and certainly one could write a grant around this. The issue was we either wanted them in or out because they were such a different group. And so we excluded. We were so rigorous, we were so, not to say draconian, but kind of. You had to be, you could not be a premature. I forget the exact cutoff of weeks we have. It might have been 37. And you could not have ever been to the NICU. I mean, there were parents that were in there an hour and were like, nope, because we just couldn't have a handle on what was going on with the child. So there were a handful of parents that were like, please. And we're like, nope, sorry. But we excluded tremendously on NICU status and preterm for those very reasons. Part of the reason is most of the, as you say, they get a lot of the false positives. And so from a random sample, we'd be getting overrun unless we stratified. But really from a grantsmanship to start without the preemies was how we decided to do it. But certainly I welcome partnership with any of the neonatologists who would like to study newborn screening. I think it's vastly understudied and underexplored. I think there's enough there's enough data to collect for many career lifetimes for different. That's my plea and plug for different individuals.
Great. We have an additional question from Rita Ryan.
Yes, hi, Dr. Ryan. Hi, Rita, who I know dearly from long ago when she was back at MUSC and also from SPR. Are you thinking that some of the cutoffs are wrong? You mean, Rita, in the original out of range? Like the original, they're set too high? It's this is the if that's the, I'll go with that as the, I think it's you mean the original cutoffs for the initial screen, Rita, if you could just type it. I think that's what you might mean. I'll go with that for now. Okay, perfect. So possibly, but as we have as we have seen, sorry, I got distracted by the question. The newborn screening cutoffs are not necessarily informed by law. I'm in this sort of lifelong slog. They're not necessarily informed by long-term outcomes. I mean, they are, but they aren't, right? So there's this, they're partial, there's this driving force of like, we don't want too many false positives, but we don't want any false negatives. So everyone's looking for the sweet spot of the golden level. And so so I think it's possible that some of these cutoffs are just too high, or some of them are too low and you're getting false positives. I also think it's possible we just don't understand the entire biology. There's been a big push, to sort of ask to get a longer term follow-up and have that loop in. I mean, I could talk your ear off and you'd cry tears about the systems level issues here of how we built a system while flying the plane and maybe need to sort of much more deeply embed the system in an iterative design, which we haven't done. But in 60 years, you can imagine people have sort of grasped onto their identities and how much it is to fund something and what the actual program is. But this is all to say that in a perfect world, we would use the outcomes to perfectly feed back in to the design of the cutoffs. We are not there yet. One can hope.
I think your next question is from Karen Eggleston, wondering if parents were involved in the study design.
Yes, not the design per se. We involved the parents. We did cognitive testing with them. So we tested on the false positives. We tested the survey, and we also cognitively tested the interview script on the uncertain project. It was very interesting to get very helpful to get the feedback. I can tell you the one minor but major thing take home point was we use a lot of, this is like, people be like, duh, but we lose a lot of jargon in newborn screening, like false positive, and parents can't quite understand that. And I think the one thing I'll say from a data validity standpoint is the parent is not, to ask the parent a simple one sentence question of, is this a did you have a false positive? If anyone gave me that study, I'd say that I don't know that. How do you know that the parent knows what they have? Not because they're ignorant, but because it's so challenging to explain and to gather what really happened in the days after. I mean, there are some parents that are told it was wrong. The testing machine had an error. I have to recollect it. That's not true. And so they believe it wasn't falsely positive. It's such a convoluted in some ways and complex process that that if we didn't have the labels from the states, it would be a huge problem. So certainly we could have had more parental engagement, and I do wonder and have thought about PCORI as a potential funding mechanism for future work related to parents and their experiences. I'll go to Rita after the second one. Illustration like decision aids. Oh yeah. So, well, I'll just say we are not far ahead in using digital illustrations. If you have, please email me if you have a good idea. Because I'm just gonna, this is how you get a career that, you start a career that can last a lifetime. We have this separate project, which I didn't tell you as part of the R01, the false positives R01, where we are helping to take the piece of paper that the primary care physicians get to help to say that the newborn screen was out of range, and then use it to tell the parents and explain what happened. This and bless the Virginia Department of Health. They're like, please help. They actually were like, please help us. I've done this in the past with Michigan. Help us redesign this. This was like your worst. It's like a HRSA grant. Has anyone ever written a HRSA grant with like 1/4-inch margins and white text throughout, because you can't shove, and there's no diagrams because there's no room to shove everything in. That's like the order of what we're talking about to give to the pediatricians, and like consent forms kind of idea, and so we've worked with Dr. Gornick, who's done a lot of Michelle Gornick from Emory, who's done a lot of work in helping with risk communication on genetic test results, and she made a few minor modifications, and you would have thought she designed some Nobel Prize thing. People are like, oh my God, this is wonderful. And so I say this because it's a great question about the concept of screening. that we are woefully behind as it relates to educating parents, but also transmitting information to doctors and providers and bringing their eyes where they need to be and what they need to do. The other, yeah, that would be great. Please do email me. This is a funny anecdote for the specialists out there. The primary care providers loved it. The specialists didn't like it. It was not enough information.
So
Which is,
I'm going to read 2 comments and then leave you with a final question in terms of time. The first comment is from Karen saying parental understanding and health literacy are such important considerations. What great learning. Thank you. I definitely agree. And from Trigve, first step is a filter with tiny circles. Second step is a filter with larger star-shaped holes. Video shows differently shaped objects moving through each. Drives the point home that the false positives aren't accidents, are dangerous. So that's probably a suggestion about the visual aids. And then our final question again from Rita is if you can comment on the move towards genomic testing and how that might impact your work.
Yeah. So there's 2 pieces at least about genomic testing. The first is the one everyone talks about, which is really, I do not believe, around the corner, which is sequencing your newborn at birth. There's 2 reasons. One, it can't fit in a mandatory screening program to have a full sequence when I don't, for adult onset disorders. 2, some of the disorders can't be diagnosed as a first pass by sequencing. So I don't think, so a plea to those of you who say, when you see work on neonatal genomic screening, there's a difference between public newborn screening and that type of screening. It's going to be very difficult to say, I'm going to sort of use the parents' patriot legal concept to have you screen your child's genome. You could filter it, et cetera, but again, as I said, it's not a helpful screen for some of these disorders. The second piece is where genomics is used as a second-tier reflex. So you go or confirmatory. It depends on how it's set in. Whereas you go through the first is probably an enzyme level test, and then you reflex and you use the genetics and you sequence or use a panel of specific pieces of the genome to say, does this child have any hotspots, if you will? The problem, or in diagnostic variants, the problem is simple. What if you don't know what you don't know? And you get a variant of uncertain significance. And then what if you have 2 gold standards and the example is CF? So you have, and sometimes the 2 gold standards don't help you. You can have a variant of uncertain. We've seen this in CF over the last decade. We're getting better. You have a variant of uncertain significance or CRMS or whatnot, and then you have a borderline sweat. And so this, to me, at the end of the day, this is science and variation, and it will be addressed through long-term follow-up with systematic data collection and linking clinical outcomes to the lab and follow-up data that we have, which is easier said than done in our disjointed and disconnected healthcare system. but we can always strive for better.
All right. Well, with that final question, I wanted to thank you so much for this presentation. I think it's so interesting and salient across multiple subspecialties and public health efforts. And it was a wonderful talk.
Thank you for having me. Enjoy your Tuesday. Take care.
Thanks, Beth. Bye.